Very excited to be here with you and to be able to present one of my favorite topics, colon cancer screening. And so we'll go ahead and get started. So I'm going to talk about colon cancer detection, a false sense of security. My name is Liz Cruz. I'm a gastroenterologist. I've been practicing here in Phoenix for over 20 years, and I had a private practice that we just shut down just a few months ago. My wonderful wife Tina and I had that practice for almost 20 years, and now I'm working for Dignity. So I'm very excited about that new position. I'm just an American girl born in LA. My parents are Puerto Rican. My mom and dad worked very hard. My mom was a secretary, that's what they call them in those days. And then towards the end, the last 15 years of her life, she actually worked with us in our practice. And my dad was a carpenter. They worked very hard. They wanted to put all their three little girls through private Christian school. And by the grace of God, I was able to go to medical school. And I do want to say that the earliest memories that I have of going to church, so I'm like a third generation Seventh-day Adventist. And my dad was a Catholic, my mom was a Seventh-day Adventist, and just because she was the one that was very devout and going to church, we by default ended up growing up as Seventh-day Adventists. And the stories that I remember going to Sabbath school, which was our Sunday school, but on Saturday, were stories of people that were out in Africa, in foreign countries, working as missionaries. And I specifically remember really connecting with the stories of the missionary doctors that were helping the people in these places that had no health care. And I just always remember thinking, that's what I'm going to do. I'm going to do that someday. I'm going to be a missionary doctor. And so I grew up. I ended up going through Seventh-day Adventist school, the school system. I ended up going to Loma Linda University, which is in Southern California. It's a Seventh-day Adventist medical school. And, always with that goal in my heart that someday I was going to go off and be a missionary doctor. And so went to medical school and then came out here with my wife and a little over 20 years ago, and started seeing patients. And at first I joined a practice, a group, and then we ended up opening up our own practice. My wife said, you be the doctor, take care of patients, I'll run the practice. Deal. So I started seeing patients day in, day out, coming in with all their digestive issues, bloating, gas, reflux, constipation, feeling tired, no energy. Anybody ever feel any of these symptoms? No. And actually, just by a show of hands, has anybody ever had a colonoscopy?
Oh, yeah.
Oh, yeah, all right.
How about the other way?
An endoscopy?
Oh, yeah.
An upper endoscopy? Okay, all righty. Very good. So these, started seeing these patients day in, day out. I would do everything I was taught to do as a gastroenterologist. Do a full workup, maybe do an endoscopy and a colonoscopy, maybe just one or the other, do blood work, do stool studies, order radiology tests, full workups, prescribing medicines like candy, because that's what I was taught as a physician. And so, that's how I was taught, and I was trying to help these patients. What started to happen, though, was that I was seeing patients, and then I started to see their kids, their grown-up children, and then I started to see their children with the same symptoms, coming in with the same issues, right? You can relate. So one day, yes, that's Tina and I, a long time ago. One day, I came to Tina, who, is our office manager, and she's running the business, and she's like, you do your thing. And I'm like, honey, I don't know what to do. These patients are coming in. I do everything on them, and nothing bad, and I'm treating them with all these different medicines, and they're still coming back not feeling well. I don't have the heart to tell that patient, hey, I've done everything I can, I'm done, you're gonna have to go somewhere else. I can't do that. I said, so I need help. And so that was the beginning of our journey to try to figure out what was the missing link or the missing links. And you would think that medical school would have been enough to teach me everything I needed to know, plus going through internal medicine residency and going through gastroenterology residency, but what we found out was that it wasn't enough. And one of the things also I wanted to throw in there is that the Navy paid for my medical education. So there was a period of time where I was serving overseas in Guam, which I know it's a territory of the United States, but for me that was like, oh, this is my first my first overseas, and I was there working at the Naval Hospital, and I got to take care of the retirees and the active duty as an internist. But there was a Seventh-day Adventist clinic on the island, and so I got to do some work there, some like help, and even a little moonlighting. And I was like, oh my goodness, this must be what God, what God meant for me to do. So, but anyways, then I ended up here in Phoenix with my wonderful wife, and then I realized, you know what? This is my mission field right here. I am in my mission field. Hi, good morning. In Phoenix, Arizona. I told Tina, I need help. We together started researching. For 2 years, we read books, over 100 books. We went to seminars on nutrition. We studied under mentors. We studied nutritional microscopy. We started this journey when Tina was pregnant with our twins. Our twins are now 16, okay? Those are our babies. And they're 16 years old now. So I remember her being pregnant, looking like a little house. And here we are going to these documentaries. And actually, when the babies were born, we were going everywhere. We'd go to downtown Scottsdale to watch a documentary on, forks and knives, and we'd be standing at the back of the theater, each of us, calming down a baby. We were so passionate about what we were doing. And Tina even went back, her background's in marketing and business, and she went back, got her certification in holistic nutrition, and together we were like, we're gonna make a difference. We're gonna help people, even these patients. She would say, even these patients, you work up, do the workup, make sure there's nothing bad, and then let's focus on nutrition and wellness. We'll bring them in, we'll start doing seminars. We were doing seminars in our office on Saturdays. We'd come in, we'd hold a seminar, have over 50 people in our waiting room, and just talk about our bodies, about digestive health, about wellness, about the food that they're eating, about what the pharmaceutical and the meat industry and the, all these industries are doing, and what we don't know about. Things that I was like blown away. We were both blown away. There'd be times I'd find her in our pantry crying. She's looking at labels at a can of beans that has sugar in it, and it was like, why? So anyways, our little babies, we always call them our organic babies because, against what our pediatrician recommended, we started feeding them. We made our own almond milk, and we would make greens with spinach, and that's what we were feeding them. And our pediatrician was angry and made us come in like every 2 weeks to check the babies. And then after a few months, she was like, these babies are healthier than the other babies I'm seeing. So, it was our mission, and together we've been helping a lot of people transform their lives, patients, clients. Tina does consults, free wellness consults with people all over the world. She just did one recently with someone in Italy. So people are finding us on the web, and we're helping people change their life, getting people off their medicines, and helping them, to realize that their body was made to heal itself. Yes. And if you feed it the right foods, it has the tools that it needs. Okay? So I'm just very excited about what Tina and I have been doing. It's been a long road, many years, and but let's talk about digestive issues that have gone wild. Okay? Let's talk about the fact that over $120 billion per year are spent on digestive issues. I mean, go into any store. Look at the over-the-counter meds that are out there. There is a ton. I believe that the digestive aisle is probably the longest one with all the different products there. 61% of the U.S. population is reported having one or more digestive issues. The thing is that before proper healing can begin, a diagnosis has to be made. And like I was already have mentioned, this means getting worked up by a gastroenterologist. If you have digestive issues, you do have to be worked up, okay? Because you want to make sure there's not something serious going on. You want to make sure there's not an ulcer or, you know, a cancer, something bad that needs to be addressed immediately and that may require treatment like surgery or something else, okay? So always get worked up by gastroenterologists, which will include, you know, the things I already mentioned, procedures, imaging labs, rule out the bad stuff. Got to know what we're dealing with, you know, to be able to be properly treated. These are the common procedures, okay? So a lot of you have had colonoscopies. You know, we use it to evaluate digestive symptoms and to rule out bad stuff. You know, people that come in with these different symptoms, rectal bleeding, and upper endoscopy. Use it also to take a look up here. Someone having difficulty swallowing, chronic acid reflux, abdominal pain, anemia. Someone who comes in with anemia but no symptoms. That person should have the full upper colonoscopy and even a capsule of the small intestine. You want to make sure that it's not cancer. The number one, second, third cause as far as GI goes for anemia is cancer, cancer, cancer for anemia. So when a person sees us for anemia, we do the full workup. And once we've done that and we've ruled out, okay, it's not a cancer in the intestine, great. Now we can focus on other things. Colonoscopy also used to prevent colon cancer, which is actually the key topic or the key thing for this topic today. Both procedures use the scope. The upper endoscopy is a little bit shorter, and then you have the longer road for the colonoscopy. Some of the screening stats that are actually pretty fascinating. 79% of people say they don't know when they should have a colonoscopy. So there's a lack of awareness and knowledge of the guidelines, and we do have guidelines in the United States. And I say that because there are countries where they don't actually have guidelines for it. 91% of those scheduled for colonoscopy describe the purpose in general terms, okay? And like among white adults, 79% knew that a colonoscopy involved inserting a camera into the body to examine the colon. Among Black adults, only 53%. So there's a discrepancy in that awareness and that knowledge. The understanding of the procedure prep also shows gap. 75% of white adults understood that a prep is required, whereas 52% of adults did not realize it. I mean, I've had patients who were like, well, I didn't know I needed to drink a prep. It's like, yes, you got to clean out so that I can see when I go in your colon. Some misconceptions that were common, 23% of Black adults believe that you have to be admitted as an inpatient to a hospital to have a colonoscopy. I mean, that's not the case. You know, we do these outpatient, pretty much 99.9% of the time. Now everything is done in an outpatient setting. And but this, you know, it just suggests that among people who know something about colonoscopy, there's still a lack of the accurate understanding of what's involved and why it's being done. So why does it matter? In 2018, only 61% of U.S. adults aged 50 to 75 have had a colonoscopy in the past 10 years. Colon cancer is one of the most preventable cancers. When I find a cancer, a colon cancer in someone, I literally, I want to cry. Like, you should hear the room. I always have an anesthesiologist, a nurse, a tech. There's always at least five or six of us. Everything gets quiet. Because everyone is sad, because we know that person should not have been found, please come in, should not have been found to have a cancer, because it's one of the most preventable cancers that there are, okay? And yet, it's the second leading cause of cancer that leads to death in the U.S., with lung cancer being the first. The American Cancer Society estimates that in 2025, over 154,000 people will be diagnosed with colon/rectal cancer, and close to 53,000 will die. Those are 53,000. Yeah, that is completely unnecessary. those deaths should not be occurring. All right? Average age of diagnosis, 66 years old. You know, a lot of the 5-year survival depends what stage you're at. You know, if it's found at stage 1, then you have a 91% survival, you know, versus 72 if it's stage 2 or 3. Once you get to the colon, cancer in the colon that has spread to the lungs or to the liver, to the lungs, now you're dealing with a much lower survival rate. If caught early though, colon cancer is very treatable, 91% survival if it hasn't spread. My point is, why wait, okay, until colon cancer is found? You know, if it's found after it spreads to other organs, I mean, your odds drop sharply. That's why colon cancer screening is so critical. And it is amazing to me that there is still such a lack of awareness of this. I have patients that I'm scoping that are, I mean, last week I had someone who was 73 years old who'd never had a colonoscopy. I was like, so did you just did they tell you get it done and you never went? Did you just not know what happened? I'm always curious, why now? Which is fine, we're gonna do it, but I'm just curious, how did you slip through the cracks? You know, and there's a variety of reasons. Some people will admit, no, they've been trying to tell me and I just put it off. You know, fear. Yeah, there's a lot of different reasons. But it's critical. Polyps can be removed before they turn into cancer, you know, or cancer can be caught at an early stage. Right? What are the options? So there are a lot of different options, and some of you may be familiar with some of these. You know, we do have stool-based tests that are non-invasive. You can do them at home, that are, you know, basically a little sample of stool, and they're looking for blood. Some of the tests will look for abnormal DNA that's been shed from a bigger polyp or even a cancer. So the nice thing about these stool tests is that they're easy. You do them at home. There's no bowel prep. It's just a little sample of stool. You know, there's nothing being put in your colon. There's no invasive tour sedation, and it's cheaper than a colonoscopy. So, what are some of these tests? You guys, maybe some of them you've heard of. There's a FIT test, which is done every year. It looks for hidden blood. It's like a little stool sample. It's good for a good sensitivity for early cancer. All right. Great sensitivity, but is that where you want to be caught? Early cancer? It is cheap, $20-50. Insurance usually pays for it. Then you have the fecal occult blood test, which has been around forever. Little card, you smear a little stool on it. Usually you get 3 of them, and then you turn them into the lab. If one of them is positive, then they're all positive, even if the other are negative. Just one being positive, that's enough to then the next step is a colonoscopy. It is an older test. There's some dietary restrictions. It is less preferred to the FIT. Once the FIT came in, that actually became more commonly used. And then there's Cologuard. Anybody heard of Cologuard? Yeah, there's commercials on Cologuard. Basically, it's also a stool sample, and it's looking for blood and abnormal DNA. This is a big one that is being really pushed by a lot of primary care providers. I see a lot of patients that come in because they had a positive Cologuard. It's more sensitive than a FIT test, but there are also more false positives. I scope positive Cologuards, people with positive Cologuards, and in the end, maybe they had a few polyps, but it wasn't anything bad, which is great. I mean, we want to get those polyps out of there before they become anything bad. It is a little bit more expensive, but most insurances are covering it, all right? So it's a Cologuard. So what are some of the cons to these tests? Well, they have to be repeated more often. If it's positive, what's the next step? A colonoscopy, all right? And it's only looking at a random sample of stool. So what if that little random sample doesn't have any blood or abnormal DNA, but then the next poop you have has some blood and abnormal DNA? Do you know what I'm saying? It's a very random. So if it's negative, it could give you this false sense of security, all right? And again, typically it detects, you know, cancer. Once you have it, it doesn't prevent it. So those are your stool-based tests. There's some other tests. Has anyone heard of a virtual colonoscopy, a CT? So this is basically a very fancy CT scan of the colon. It's done in radiology. It's actually a very cool test. When I was doing my fellowship in gastroenterology, we got to rotate with the radiologist to watch them do this test so that we would be familiar with what it is. So this one, you could see on image B, the arrow is pointing to a polyp, a lesion that the radiologist can see. And then to the left is the actual colonoscopy that is pointing to that polyp that the gastroenterologist who's doing the colonoscopy is seeing. So it's really awesome. It's non-invasive, it's quick, you don't get sedated. Again, like I said, it's a fancy CAT scan of the colon done in radiology.
Does it require the cleaning stuff to make it show up? I can't think of
Like contrast?
Contrast.
They do put some contrast in through the rectum.
They do?
Yes.
Okay.
Yes, yeah, great question. Yeah, they do put contrast to the rectum.
Right.
I use this test. I have ordered this test through the years. I use it like in maybe someone who can't tolerate anesthesia, or someone is deathly afraid of having a colonoscopy, even after I've talked to them and they're like, nope, then I will offer them this. I would rather do this than the stool studies.
Sure.
I would rather do this one. To me, because look, your radiologist is looking and they can see things. If they're advanced age, they don't want to, or they have a lot of medical conditions, they don't want to have a colonoscopy, or I don't feel that it would be safe to, put them through that, then this is a test that I would consider. Or let's say they did try to go for a colonoscopy, but for whatever reason it was a difficult exam, then that would also be an option. So those are some of the pros for it. However, cons, it still requires a prep. It still requires a prep because the only way the radiologist could get that view is with your colon being clean. If you're not clean, stool balls could be mistaken for a polyp. So you have to prep, and if something is found, then the next step is going to be you need a colonoscopy. So now you've taken 2 preps. Okay, now you've taken 2 preps.
That's the worst.
The prep, yes.
Yeah, that is.
Yeah. And it does expose you to some low dose radiation because it is a CAT scan. If the polyp is less than 5 millimeters, very tiny, it may not pick those up, especially if they're flat. It's just, it's not going to pick up certain smaller lesions that you could see with a colonoscopy. And the frequency of it would be every 5 years. All right, it depends on what's found, but on average, every 5 years. In my experience, out of everyone that I've ever scoped, approximately like 60,000 people, 75 to 80% have at least one polyp. At least one polyp, and at least 50 to 60% of those polyps are precancerous. So just my little plug as far as why the colonoscopy is still number 1 in my mind. Flexible sigmoidoscopy. Anybody heard of a flexible sigmoidoscopy? It's a shorter scope, uses the same camera for colonoscopy. As you can see, we only go up half, not even halfway, but just on the left side of the colon. Whereas a colonoscopy, you go through the entire colon with the camera. It's less invasive, it's quicker, it's simpler than a full colonoscopy. But what are some of the cons? Does require prep, and in the end you may still need a full colonoscopy, okay? I've always compared the flexible sigmoidoscopy as doing a mammogram, but just doing the left breast, right? You're totally missing the right side, and that's what happens. You're gonna miss polyps on the right side. This used to be what we did for screening up until the year 2000, when colonoscopy became the gold standard. And the year 2000 was my first year of fellowship, and I remember the guidelines had just come out for colonoscopy to be the gold standard, and some of these old school gastroenterologists that have been doing flexible sigmoidoscopy had a very hard time switching over. But basically, because the studies showed, hey, you guys are missing polyps and cancers on the right side of the colon. Why aren't we doing a full colonoscopy? So it's no longer recommended as screening. I will use it from time to time. If I just did a colonoscopy on someone 6 months ago and they were feeling great, now they come in and they're just having like diarrhea, not bloody diarrhea, just diarrhea, and I've done every, stool studies, everything is negative, I may say, you know what, we just did a colonoscopy 6 months ago. We don't have to do the full exam. Let's just do a flexible 6 so that I can go in and do some biopsies and we could rule out some microscopic colitis. So that's how I use a flexible sigmoidoscopy. But it definitely is not a test that's used as commonly as it used to be. Ta-da! I don't have a drum roll. However, colon cancer screening, colonoscopy is the gold standard. It has been the gold standard since 2000, so 25 years. It has been considered the gold standard. And like I showed you in the previous, with the colonoscopy, the scope is inserted and it's going all the way through the entire colon, which is like 5-6 feet long. Ooh. It saves lives. Colonoscopy saves lives. Like I said, there should be no one being diagnosed with colon cancer anymore. We should not be having deaths from colon cancer anymore. There's no reason for it. And it's obvious to me that there's just a lack of awareness of the guidelines. And so it's become my mission to try to teach and try to push this message out as much as we can. It's so important. We find polyps so that we can remove them, get them out of there. Screening, typically covered by insurance. It could, as far as how often, it depends what I find. If I find multiple polyps on that person, and depending on the pathology of those polyps, I may bring them back less than 5 years. Depending on if they were cleaned out well, sometimes I get in there and the prep is not the greatest, but I'm able to still get all the way through. I may say, you need to come back in a year or 2 years. So it just depends on what we find, depends on the prep, but it saves lives. That's the bottom line. It saves lives. It is invasive, so I am putting the camera into your colon. It does require sedation. I have done colonoscopies on patients without sedation, and it is not a pleasant experience for them, nor for me. So if anyone ever comes now and they request it, I tell them you have to go find someone else that's willing to do it, because if I'm putting that camera in, putting air in there, and you start moving, it's dangerous. It's not safe. I'm not going to put you at risk for that.
Why would they want that?
Maybe they don't have a ride. Maybe it's just someone that's just afraid of anesthesia. There's different reasons I've heard through the years. So it is invasive, it requires sedation and a prep, and it could be costly if it's not covered by insurance. I mean, most insurances will cover it these days. There have been, but there's still stuff. There's co-pays, there's deductibles. Some insurances, if we take off a polyp, will come back and say, oh, you found something, so now it's not a screening, so we're going to charge them. Like, that's not right. I mean, this has been an ongoing battle for a long time. But for the most part, insurances will cover a screening colonoscopy. What are some of the reasons why people avoid colonoscopy? And some of you have already thrown out some stuff. They're afraid of the procedure. They're afraid of what I may find. All right, they're afraid of that. Disgust with the prep. I would have to say that's probably the biggest one that I've heard through the years. Oh, my dad had one, and that prep he had to drink was horrible. Or I had one 20 years ago, and that prep was horrible. So yes, disgust at the prep is a huge one that I've heard through the years. Cost concerns, maybe lack of insurance, having to get time off of work. You can't work on that day. You cannot work on that day. Some people even want to take the day off before because of the prepping. I've done 2 colonoscopies that I've had on myself, and I've worked the day before. And it is challenging because you can't eat. You're just drinking clear liquids. You just have to make sure you're drinking a mix of some clear liquids with a little sugar and some with some salts. But it can be done, but a lot of people will take the day off before. But yes, it does require time off of work. And so sometimes those can be issues. Lack of awareness or misperceptions. I feel fine. Why do I have to have this? I hear that. I've heard it many times. Hey doc, why do I need to have this colonoscopy? I feel great. I'm like, because I want to keep you feeling great. Okay, polyps are not going to cause symptoms. You don't want to wait until you're having symptoms because it might be too late. It might be too late. So now is a time when you feel great. Let's go in there. If I find polyps, I take them off and let's keep you feeling great. Maybe not understanding the guidelines like we talked about earlier in the top. Some believe that it's optional. And I mean, yes, of course, it's optional, right? You have the right to determine if you're going to have any of the screening tests, pap smears, a prostate exam, or PSA, or mammogram, screening colonoscopy. So yes, it is optional in the sense that it's up to you. However, these are guidelines that are put out there because it's to prevent cancer. It's to prevent cancer. So, you know, again, the goal is to prevent. I don't want to get in there and detect that now you've got a cancer in there. We want to prevent. Cultural and racial gender factors. This is actually very huge. I've had women from other countries, you know, that for cultural reasons, when they get there will be, do you have a female anesthesiologist? Do you have a female tech, a female nurse? And that's been an issue because unless we know that up front, sometimes I don't know who my team is going to be until the day I get there. So I may have a male anesthesiologist, and then now we're scrambling to try to find a female anesthesiologist in the center that can maybe help us for that case. So these are issues, and we have to be respectful of all of that. Those are cultural things. Medical distrust, that's a huge thing. I feel like there's more and more been distrust of the medical community. I feel like it worsened. It's worsened since COVID. And then you have gender dynamics. Again, that's always a big thing. So these are all issues that we have to be aware of and that we have to be respectful of. Cognitive biases, avoidance, procrastination. I feel great. Oh yeah. My doc kept telling me every year, go get a colonoscopy. I just kept putting it off. I didn't want to do the prep, you know, or I didn't want to be put under, or I feel great, or I'm not going to get colon cancer. That's not me. No one in my family has it. Can't tell you how many colon cancers I have found where there is no family history.
Wow.
Okay, it was just, and I can probably count on my hand because it hasn't been a lot, but in my over 20 years of doing this, probably between 5 and 10 cases of people who just came in for screening. No symptoms, just screening colonoscopy, who I did find a cancer on. So it's rare, but it has happened in my career. But here's the thing, is any of this worse than being treated or dying from colon cancer? I mean, when people talk to me about the prep, I mean, honestly, I've just gotten to the point where I lovingly tell them, look, I would rather torture you with the prep than to come out and say you've got cancer, because now your life is on a different pathway. All right? Now you're looking at surgery, possible chemo, possible radiation, coming in now every 6 months or every year, you know, so I would rather torture you with the prep. Just get it done.
Just do it.
Just do it. Just do it. What are the guidelines? So these are guidelines that are set forth here in the United States for average risk, meaning there's no family history of colon cancer. The age is 45. It used to be 50. The guidelines changed, I think like in 2018 to 45. Why? Because we were finding cancer in younger and younger people. One of my very first patients I took care of when I started my fellowship was a 26-year-old girl who had been found to have rectal cancer. No family history. I remember that because she was one of my first patients. So you just don't forget cases like that. But 45 years is the guideline for no risk, low risk. What's high risk? Family history of colon cancer in a first-degree relative. So a mother, a father, a sibling, that would be first-degree relative, especially if they're under the age of 60. Especially under the age of 60, even higher risk. Or 2 or more second-degree relatives. So an aunt, an uncle, grandma, grandpa, a first cousin, those would be considered, but the risk is not the same as if it's a first degree relative. Let's just pretend that your mom had colon cancer at the age of 45. She was diagnosed. All right, so which one? So it's either at the age of 40 or 10 years younger than when they were diagnosed. So she was 45, so 10 years before that would be 35. So you would need a colonoscopy at the age of 35 as opposed to 40, okay? All right, so that's our screening colonoscopies. Now, if you're having issues, if you're having symptoms, if you're having abdominal pain, if you're having diarrhea, and sometimes I'll get a person that comes for a colonoscopy and I look at the history, because typically at the clinic at downtown Dignity where I'm working, I do procedures. In the office they have nurse practitioners that are seeing the patients. So when they get seen by the nurse practitioner, they'll get scheduled. Well, I always go and talk to them before we take them back. Just want to make sure nothing's changed. This is just a screening. Well, I've been having some diarrhea and some rectal bleeding. Now that is not screening anymore. Now it's become diagnostic, because now we're going in to try to figure out why you're having these symptoms. So but if you're having issues, like I've said earlier in the talk, get checked out, go see a gastroenterologist. If you want, you're welcome to come down to Dignity to see us. But find a gastroenterologist and get worked up, get your workup done to make sure that there's nothing bad going on. What are some of the questions that I get? The common stuff I find in a colon are polyps, very common, and diverticulosis. You guys familiar with diverticulosis? All right, I've got a little picture just showing you a little diagram of diverticula. So when I go in the colon, what I see with the camera is the opening to these little pockets, all right? These are little sacs, little pockets that develop over the course of time. And what I see are those pockets, and typically diverticulosis is more common on the left side of the colon, but every once in a while you can find them on the right side. The studies show that right-sided diverticulosis is actually more common in Asian population, and we don't know what the reasoning for that is. But diverticulosis, very commonly I see that. So then I go and I talk to the patient once they're awake. Hey, you did great, nothing bad. I did find these polyps, and you have some diverticulosis. And I'm finding diverticulosis in younger and younger people in their 20s and 30s. And so they're like, well, doc, some of the questions, how can I avoid getting polyps? So I just tell them, I'll tell you in a little bit what I tell them. I can't believe I had polyps, they tell me. Some people are like, I eat a green salad every day, I'm so healthy. Hey, how can I avoid worsening my diverticulosis? Or once they are waking up more, they're like, what? I have diverticulitis? I'm like, no. Diverticulosis. Diverticulitis is when one of those pockets gets infected, all right? That's not what you had. I found, now every once in a blue moon, I will find an infected pocket. And then on that person, I'll get them started on antibiotics. But I'm like, no. So a lot of people have heard of diverticulitis. Maybe they have a parent or a grandparent that's had it and was very sick with it. And so they're like, what do I need to do? Doc, what does this mean? Do I need to keep taking medicines I'm taking forever? Well, what about my reflux and my gas and my bloating? And actually I hear this a lot, because I'm like, okay, well, remember, today we were doing a screening colonoscopy. If you're having reflux, you're having pain, bloating up here, you need to go back to the clinic so they can reevaluate. Maybe they need to schedule you for an upper endoscopy. Maybe you need an ultrasound, a CAT scan, some blood work, rule out celiac disease. So screening colonoscopy, we use it to remove polyps and of course rule out bad stuff. We may not necessarily find the cause of GI symptoms. I mean, sometimes if someone's coming in, they have lower abdominal pain, constipation, diarrhea, I may not find anything. I mean, everything, maybe they'll have a little diverticulosis and some polyps, but that's not the cause of their symptoms. And so those people need to continue to be worked up, maybe get a CAT scan and some other testing. So I tell them, Okay, you have polyps? You need to, if you eat red meat, if you eat processed meat, that's the number one thing I always tell them, because we have studies. There's studies that have been done on populations of people who eat a lot of red meat and processed meat versus populations of people that do not. And the incidence of colon and rectal cancer is much higher in the population of people that eat high quantities of red meat and processed meat. Bacon, sausage, packaged deli meats, all that stuff. All of those are processed meats. So I always tell them, you need to cut, if you eat that, you need to cut your intake down significantly. You need to make sure you get good fiber in your diet. I had a patient ask me a few months ago, hey doc, what about peanut butter Captain Crunch? Am I getting some good fiber there? I'm like, no, not at all. But I'm telling you, there is a lack of awareness, and people are honestly asking me these questions, and so I was like, no, it's not a good source of fiber. There is no fiber in Captain Crunch.
Just sugars.
Just sugar, exactly, just sugar. So sometimes I'll tell them, you've got to eat a lot of greens. Well, I don't like greens, or I have one salad a day. I'm like, that's not enough. Your body thrives on raw food. You need greens. Greens is what builds your cells, which is what builds healthy tissue, healthy organs. You need greens. And if you're not getting enough greens, you need to increase, and I'm not talking about green peas. I'm talking about green, leafy vegetables, okay? And if you don't want to do it, then get my greens, okay? And when Tina and I went on this journey, one of the things we did was we were using a lot of supplements. We learned how to use digestive enzymes, detox, greens, and we were getting stuff from manufacturers. And then finally, when Tina was struggling with companies that were like, yeah, we're on back order, we're like, let's start making them ourselves. We're going to formulate it and we're going to make it ourselves. So we formulated, came up with our own formulas, and now we manufacture our own supplements. And so I'll tell patients, get the greens. Here's my website. Get on the green capsules. You're going to get greens without having to eat greens. Okay? Get on the greens. I also tell them, detox. Detox is so important. Your body's exposed to toxins every day. The air we breathe, lotions, perfumes, the food we drink, the eat, and the drinks that we drink, all the chemicals you put in your body works very hard to detox. And it's very hard for your body to keep up because there is so much we're putting into it and that we're exposed to. So I tell them, take a detox. And one of the biggest things that we have been using through the years with our patients and our clients is our detox, which is a gentle detox that you take every day, and it works systemically. And we tell them, get on probiotics. Get on probiotics. Probiotics. Your intestine is jam-packed full of bacteria, trillions of bacteria. However, sometimes the balance gets thrown off with foods that we put, medicines that we take, different things will throw it off. And so your intestine could always use good bacteria. 80% of your immune system is in your gut, all right? So by you taking a good probiotic, you're just supplementing and filling it up with good, healthy bacteria that's just gonna help you stay healthier. It's gonna help you in the long run in many ways. And increase your water intake. In this country, we are the most dehydrated society. We really are. We drink everything, fancy coffees, energy drinks, sodas, everything, except water. We don't drink enough water, and your body needs water so that your cells can work properly, so that you can flush out properly, detox. I mean, your body needs water. So we always tell people, rule of thumb, drink half of your body weight in ounces. And people will look at us with big eyes like we have a third eye. They're like, what do you mean? And so we always tell them baby steps. If you're drinking, if you're drinking 2 bottles a day, increase to 3 bottles a day every day for a week. Then increase it by another bottle. But water intake, very important. Basically, when they're telling me this in the recovery room or even in the pre-op before we take them in that they're having symptoms, I always tell them, have a complete GI workup, go back to my clinic, let the nurse practitioners finish the workup. And I say that also to you today. If you're having any issues, if you haven't been worked up, if you're due for a screening colonoscopy, please get it done. If you're having issues, if you need a gastroenterologist, we're happy to see you, or find someone. There's gastroenterologists all over the valley. And maybe consider getting on some of the, the probiotics, the enzymes. We have super salts also, which are basically electrolytes that you put in your water. We're losing electrolytes every day. Every day you sweat, whether you're inside or outside, you're sweating and you're losing water. And we lose electrolytes with that. And then we also have food sensitivity testing that we offer our clients. I would have to say that the biggest thing that we have offered our patients and our clients through the years, and even after I finish the colonoscopy, I have a little brochure and I tell them, here, schedule a free 30-minute wellness consult, free. It's done over the phone. You could do it from anywhere. Like I said, we have a team of nutritionists. Tina has done consults in Australia, in Italy, because people are finding us on the web. And if you go to our website, you'll find, Tina and I have been podcasting over 10 years. We have over 500 episodes on our podcast. And it's timeless information. It's all pertinent, a lot of great information. We have free ebooks, we have a newsletter. And like I said, a free 30-minute wellness consult, that's our gift to you. All right, so, we've got one of the things that we have prided ourselves on through the years is that we started out as a standard gastroenterology practice, and then what happened is that we morphed into becoming more holistic and applying more holistic, combining it, marrying it with the traditional and having more holistic approach. So we have, through the years, we had other gastroenterologists that would do a workup on their patient and then send them over to us for the holistic side of it. And it's been wonderful. We've helped so many people. And so number one, if you haven't had the screening colonoscopy, what are you waiting for? Get it done. And number two, if you have any digestive issues or anything, we'd love to help you out. We'd love to be there for you. So please check us out. We have a lot of great information.